Shall we begin, Anne?
Yeah. Okay.
Okay.
So, do you want to go ahead, Julie?
Unless you want to.
Okay, I'll go. Hi, everyone. My name is Anne Cheney. I am co-chair for Ucr Healthy Campus, along with Julie Chabdi. I am faculty in the Ucr School of Medicine in the Department of Social Medicine, Population Public Health, and I am happy to be here to help facilitate this conversation that we will have today. I will go ahead and pass it over to the co-presenters so that they can also introduce themselves.
Hi, everyone. I'm Julie Chabdi. I'm the Wellness Program Coordinator for UCR Faculty and Staff Wellness Program and co-chair of Healthy Campus.
Hi, everyone. I'm Devin Sakamoto. I'm the Director of the Well and on the Planning Committee for this forum.
Hi, everyone. I am Marisol Torres. I'm a health educator at the Well and also part of the Planning Committee.
Great. So this is a collaboration between Healthy Campus and the Well. We can move on to the next slide, please. So first, we want to recognize the lands that we are on. We at UCR would like to respectfully acknowledge and recognize our responsibility to the original and current caretakers of this land, water, and air, the Cahuilla, Tongva, Luiseño, and Serrano peoples, and all of their ancestors and descendants past, present, and future. Today, this meeting place is home to many indigenous peoples from all over the world, including UCR faculty, students, and staff, and we are grateful to have the opportunity to live and work on these homelands. So just a few housekeeping. I imagine that everyone is quite familiar now with Zoom. So we will be using the breakout function. Right now, we ask that people mute themselves. You can choose at the moment if you would like to have your video on or not. We do ask that when we go into the breakout rooms that you turn your video on if that's possible, and that you unmute yourself when you'd like to speak, particularly in the breakout rooms. And I believe that that is it. Well, we do want to let you know that when you go into the breakout rooms, first you'll be assigned to a breakout room and you have to accept that. And then when you enter into the breakout room, you'll be then there for about 40 minutes, 45 minutes. Then you will have another prompt that will request that you leave the breakout room and go back into the main meeting. It's very important that you do not click leave meeting, but that you leave the breakout room. Okay, next slide. So we would like to hand it over to Dean Dees, our Vice Chancellor, the Dean of the School of Medicine, as well as the Vice Chancellor for Health Sciences here at UC Riverside, who will be providing our welcoming remarks.
Thank you so much, Anne. Good afternoon and welcome to today's Healthy Campus Public Health Anti-Racism Forum. As Vice Chancellor for Health Sciences, Dean of UCR School of Medicine, and UCR co-champion for Healthy Campus, I am delighted to offer opening remarks to set the stage for today's program. First, I would like to thank each of you for taking the time to participate in this forum. Your presence is indicative of your commitment to working toward the creation of an anti-racist UCR campus culture. I'd also like to thank UCR Healthy Campus, Julie Chabdi, and Anne Cheney, co-chair for UCR Healthy Campus, as well as the Well, for creating a venue for this timely and necessary conversation. Today's agenda will provide an opportunity to view both systemic and individual racism with a public health lens and discuss its impact on health disparities and health equity. The UCR School of Medicine proudly embraces diversity, and our mission places great emphasis on improving the health of the historically underserved in the Inland Empire, consisting of Riverside, San Bernardino, and Imperial counties. The Inland Empire region is rapidly growing, and it will become one of the most populous areas in the United States over the next 5 to 10 years. It has a diverse population of more than 4.3 million people, and is characterized by a severe shortage of healthcare professionals, particularly in primary care. In Riverside County, the healthcare trends across racial lines tell a story that many of us are all too familiar with. Current data show that African Americans in the county have higher emergency room and hospitalization rates for hypertension and higher emergency room rates for asthma and diabetes than other races and ethnicities. African Americans trail only Latinx in the percentage of adults without insurance. Latinx and African Americans suffer disparately from poverty, poor health outcomes, low educational attainment, and overall well-being. On August 4th, the Riverside County Board of Supervisors unanimously passed a resolution declaring racism a public health crisis, and specifically citing systemic racism as a cause for persistent racial discrimination in housing, education, employment, transportation, and criminal justice. Before 2020, the average American may have been hard-pressed to speak on or draw any associations between these social determinants of health and systemic racism. Unfortunately, the events of 2020 have created almost daily stories of systemic racism that have forced these terms and concepts into our national conversation. The global COVID-19 pandemic has served as what many are calling the Great Revealer, highlighting the crisis within a crisis, as disparities and inequities in our healthcare system disproportionately affect people of color battling the coronavirus, especially African Americans, Latinx, and Native Americans. Latinx make up 39% of the population in California, but account for 56% of COVID-19 infections and 46% of deaths. To make matters worse, the deaths of George Floyd, Breonna Taylor, Ahmaud Arbery, and Rayshard Brooks have also served as tragic reminders of the impact that systemic racism, discrimination, and police brutality specifically have on Black communities across our nation. A byproduct of this increased awareness of racism as a public health impediment has been the outpouring of support and activism from people of all walks of life seeking to join the fight against systemic racism. As we continue our attention to issues of racial disparities and inequities, it's imperative to recognize that while this increased awareness of the ills of racism is important, it's not enough to truly turn the tide. We must come together to devise the policies, procedures, and best practices needed to dismantle systemic racism and remove its ugly stain from the fabric of our society. I believe today's forum is a great opportunity to discover how we can collectively address the racial inequities that exist in our campus culture. We must do this together. In the words of the African proverb, if you want to go fast, go alone. If you want to go far, go together. Thank you. I now turn this over to Julie Chabdi.
Great. Thank you so much, Dean Dees, for your inspirational welcome and remarks, and for your continued commitment to health and well-being at UCR and your support of Healthy Campus. Next slide, Evelyn. So I'll be providing a brief background of UCR Healthy Campus. Healthy Campus is part of the larger UC system-wide Healthy Campus network, in which former President Janet Napolitano provided an initial financial investment for each campus to create cultures of health at UC. Here at UCR, we are very fortunate to have the support of leaders like Dean Dees and our Chancellor, as you can see from his statement of support. He states, UCR Healthy Campus is a comprehensive approach to elevate health and well-being at UCR. We are committed to the health of our faculty, staff, and students, and embrace an environment that both supports and encourages the health and well-being of our campus community. Next slide. UCR Healthy Campus provides a framework to bring health and well-being to all aspects of UCR and creates a community where health is a priority. Our goal is to ensure that health and well-being is the norm, is inclusive of all members of the campus community, and creates a healthier environment for all. Next slide. Here's a look at the leadership team. Dean Dees serves as our senior leader and champion for Healthy Campus. Dr. Ann Cheney and myself are co-chairs, and we also have an advisory committee of students, faculty, and staff. And the next slide. Here you'll see our Healthy Campus vision and mission, as well as our subcommittees. Each subcommittee consists of faculty and staff co-leads with membership from all campus constituents. I am proud to say that we have and continue to accomplish so much together pre-pandemic and through this challenging time. We continue to offer, develop, advocate, and inspire our entire campus to improve physical, mental, social well-being in so many different ways. We welcome all voices, and we continue to strengthen our networks and infrastructure. If you want to be involved in Healthy Campus, we welcome you, and we're very pleased to see the turnout for today and hope that many of you will continue to engage in our efforts. And with that, I will turn it over to Devin Sakamoto, Director of the Well.
Thanks, Evelyn. You can go to the next slide, please. So I was just going to take a minute to talk about the evolution, how this idea for the subcommittee came about. So the idea for our new subcommittee came about after a series of discussions between the WELL, which is UCR's Student Health Education and Health Promotion Department, and Healthy Campus. Like Julie just mentioned, Healthy Campus has a framework and an infrastructure in place and a wide reach across campus to a variety of stakeholders. We were interested in dedicating some efforts specifically to anti-racism and health equity work within Healthy Campus. We thought if a dedicated public health committee could be created to tackle the COVID-19 crisis, we wanted to develop a public health committee to look at the racism crisis through a public health lens. We also want this subcommittee to be built and shaped by people interested in furthering the work, determining the structure of the subcommittee, determining its mission and its vision. So our first step toward building our subcommittee is holding this forum. Thank you all for your participation today and as the committee grows.
Okay, thank you, Evelyn. So thinking about the goal of today's forum, really, we are all here today to bring together diverse voices and perspectives. So when we go into our small breakout sessions, you'll notice that there will be students, faculty, staff, as well as administrators. So we're very purposeful in making sure that we have representation from different stakeholders within our campus community. You will discuss how racism exists in our campus culture. So you will consider, how does it present itself in our working and learning environments, in our campus events, and also in our activities. And the idea is to pull on from what you know, what you've seen, what you've observed, what we've experienced. And also you'll discuss the existing efforts and how we can build on them. So we recognize that there are already a number of things that faculty, staff, students, administrators are currently doing. And we want to recognize what we're doing and build on these things. As well as we'll identify actionable steps toward creating an anti-racist campus culture. So what can we do collectively? What can our broader community do, including the city of Riverside in this larger area where the campus sits, as well as thinking what individuals can do or what we can do individually. The expected outcomes are to identify actionable steps that we as a campus community can move forward, and then to create an anti-racism subcommittee. A few things to consider. So we shared with all of you a handout that provided some background information as well as some terms. And we want to just briefly review the idea of racism as a public health crisis. So when we thought about creating this subcommittee, one of the things we really wanted to acknowledge is that structure and structural or inequalities within institutions and within structures, that they are harmful. So structural inequality and systemic oppression, particularly for people of color, that they are harmful. We also want to acknowledge, particularly by leadership, non-Black people of color in positions of power and authority, to accept as truth the health effects of race-based inequalities on people of color. We also want to touch upon this idea briefly of institutional and systemic racism. So this is a concept that we have been talking about for some time, and we'll specifically talk about this today during our small group discussions. You'll have an opportunity to share your thoughts and ideas. But when we think about it, one definition that we're using for institutional and systemic racism, it refers to and includes those policies and practices that are entrenched in established institutions. That includes higher education, which result in the exclusion or promotion of designated groups. So moving on. And I will hand it over to Marisol.
Thank you. So we just want to make sure to go over a couple of ground rules for the forum. So first, come ready to learn. So commit to learning, especially learning from others during this time. Use inclusive language. So remember to include and not exclude anyone with your words. For example, using the correct pronouns. Accept your privilege. So recognize where you are granted advantages where others are not. Allow everyone a chance to speak. So if you feel that you've been doing a lot of the speaking, maybe step back a little and allow others to do that. Speak one at a time. So again, don't speak above others. Avoid assumptions about any member of a class or any generalizations, and do not ask individuals to speak from their perceived social group. Keep information confidential. There will be time in our small groups where people might share private information, and we welcome it and we really want people to feel comfortable, but we ask that you keep it here within the forum. And then a little bit more of just kind of technical things. Please mute yourself when you're not speaking, and if you're able to, please turn off your cell phones or technology that may be distracting. And then lastly, make sure you take a break if you need one. We won't have a scheduled break during this forum, but especially if you're feeling a little bit overwhelmed or just need to step a little bit outside, feel free to turn off your camera, mute yourself, and take a minute for yourself. And next, Devin will tell us a little bit more about some of those resources available for you.
Thanks, Marisol. So these topics might be difficult for some people to talk about, and we wanted to highlight some key campus resources that are currently in place, both for additional information and trainings, and also for a place to speak confidentially. So the Office of Diversity, Equity, and Inclusion is committed to sustained and comprehensive work of creating a campus climate of mutual respect and communal vision at UCR. Their website, which we've listed here, contains data, training opportunities, additional resources for learning, and more. And that's open to everybody on campus. For students, counseling and psychological services is currently closed to in-person appointments, but they are still very much seeing students for virtual appointments. Students can call to schedule an appointment or visit their website for links to additional self-help and support resources. The Office of the AVC Dean of Students is comprised of various departments, including all of the ethnic and gender support programs, with multiple initiatives and programs united by one common goal: to provide students with the most enriching UCR experience possible. For staff and faculty, all faculty and staff have access to the FSAP, the Faculty and Staff Assistance Program, which is designed to offer confidential counseling, referral, and other needed services to staff, faculty, and their family members with personal concerns.
Great, thank you, Devin. So now we'll transition, and it's my pleasure to introduce our AVC of Diversity, Equity, and Inclusion, Miriam Lamb, and her colleague, Willis Harris, to give us a brief presentation to get our conversation started. So I'll turn it over to Miriam and Willis.
Thanks, Julie. And I can share my screen, right? We have a PowerPoint.
You
Yeah.
should be able to.
Okay. I'm going to minimize this and then. Can everyone see that all right?
Yes.
Okay. And Willis, jump in whenever you feel like it. So Julie and the whole planning team asked Willis and I to speak for about 20 minutes, kind of laying out larger issues and parameters. And they did a nice job of introducing, and Dean Dees, Vice Chancellor Dees did a great job of setting up the tone of the seriousness of the topic. Willis and I wanted to linger a bit on racism as a public health crisis, right? That is, we can talk about health disparities in the COVID situation, but we also wanted to talk about racism as embedded in a much longer history of crisis, right? Not just this current moment. And then what would it mean in a future-facing fashion to think about treating racism as a public health crisis indefinitely, right, into the future? And how would that change different notions of individual, institutional, and systemic racism as a whole? So I wanted to start with showing you two quick videos, just 2.5 minutes of the first one and 3.5 minutes of the next one.
It's important for it to be noted that the conversation that's happening nationally is a very important one, but the circumstances aren't new.
They walk to express to the nation in a peaceful fashion their rights.
We're traumatized just by the systemic fact that we've been under oppression for over 400 years. And though we may not be on the bottom of votes anymore, but we certainly at the bottom of education. We may not be in the cotton fields for free labor, but you're certainly getting it from us now.
It all just comes down to that we're in a state of emergency because Black people are dying.
Clearly, I have missed the boat in some way as an elected leader. I recognize that. I now need help fixing that.
Resolution affirms that racism is a public health crisis that results in disparities in family stability, health, and mental health wellness, education, employment, economic development, public safety, criminal justice, and housing.
All those in favor?
Aye.
16 yeas.
This will finally give some teeth to some things that we've been working on here in Milwaukee County for quite some time.
Tonight's zero notice item is for student place on file.
When you make a declaration and you tell people
this is a crisis under CDC guidelines. Now you have to do whatever you can to mitigate the crisis. We look at this as racism being the other pandemic that we're experiencing right now.
And it really felt we've come to a cultural and societal moment where it is just pivotal that we say collectively, racism exists, it's been wrong, it's wrong now, and we have to join together and do everything we can to eliminate it.
And it's unfortunate that an event, a circumstance such as George Floyd had to happen for them to shine even, a light or get a closer lens into what disparities are affecting Black Americans. If we do not address this moment now, Black people are going to continue to remain in that cycling of suffering.
What I brought to the table on this was, let's not just do a resolution, but let's have a plan for work after we pass it. And that's where I said, let's create an element group of the countywide vision to really dig into and work on the topic. And our shared goal is to identify, eliminate the effects, and prevent racism.
It was all 5 yeses and no nos. I was excited, but then right at that moment, I couldn't celebrate too hard because I said, well, there's still work to be done. There's still work to be done. This isn't just a resolution. This is on paper, but we got to make sure there's actionable steps put into place. This cannot be performative.
Okay, and then I wanted to show the next video, which is talking about the CDC, the Center for Disease Control, which already recognizes that the leading cause of death in the United States is secondary stress and anxieties and health illnesses that are caused from workplace anxiety and stress.
It's important.
Our question is, how do we know that racism is affecting the health of people, all people in our country? I believe one of the things we're seeing, and particularly in primary care, is an increase in anxiety disorder and those pathologies associated with it. Hypertension, poor health choices, lifestyle problems, obesity, binge eating disorder, these kinds of chronic problems that we can no longer afford, as we're also beginning to have economic stresses on our healthcare finance. We have a campaign pushing back against the government or the Centers for Disease Control and Prevention to force them to do what they're empowered to do, which is prevent and control disease for the public. I believe racism meets that 4 criteria that they have for that threat, and we're trying to ask them to do their job, particularly now that we have evidence that it's directly related to everyone's health, not just the health of people of color. So CDC has 4 criteria for what constitutes a threat to public health. One is that it's a burden. It's an economic burden on the culture. The second is it's disproportionately shared by a section of the population, whether that be female, gay, pregnant, smoker. But the other is that it shows that current measures are not enough. So in other words, that problem is continuing despite what's being done currently. And the last one is that there's evidence that upstream change will affect that problem. In other words, institutionality, the institutional problem of it. What we're saying is racism meets those 4 criteria. So we're asking that CDC do their job, declare it a threat to public health, and then follow the protocol just like did for other public health problems in the past. Zika, HIV, smoking, diabetes, these other campaigns. The way that we want to do that is it needs to be effectively, definitively, and publicly announced as the threat that it is. That way, people can then begin to speak about racism and less about health disparities, social determinants of health, these other code words that have currently been used. We are saying if CDC will do that, we will begin to save the disproportionate number of healthcare dollars, lives, unfortunate incarceration, gun death. So much of the underlying cause will be mitigated, and that money will be saved and put into education, healthcare, the kinds of things that we now know have been neglected instead. Because in primary care, the idea is not just to treat the symptom, we pursue the cause of the symptom. It seemed only reasonable to apply that to this particular inequity. as time has gone on, we've begun to see more and more how that same underlying cause, racism, also harms people who are not marginalized, people who are not targeted by these inequities. We want equity, health equity for our entire population, and for CDC to recognize those 4 criteria and realize it's not a mental health problem, it's not a political problem, it is a public health problem. Handle it. Our question.
Thank you to Willis for curating those 2 videos. As you saw in the first one, many of these are very local, San Bernardino, Fontana, city of Riverside, right? And so some of which Anne already covered, but it's important to think about both overt and covert forms of individual racism, sexism, homophobia, and all the intersectionalisms, and then also institutional in terms of what we can do as a campus, right? But then also the systemic forms that the speaker speaking about the CDC just covered, but also how our institution is embedded in larger systems of higher ed and medical healthcare and such. And so as we try to address them, we all have to try to address them on as many levels as possible. And Julie and Ann asked us to talk about health disparities versus health equity. And so, you know, quickly, you all have heard about the health disparities, especially around COVID-19 affecting Black, Brown, Indigenous populations, right? Undocumented, homeless, queer, non-gender binary folks, right? In disproportionate ways because of already marginalized access to healthcare and affordable preventative care and such. And so health equity is really about a commitment to the highest level of health access and affordability for everyone, right? And with particular attention to those at higher risk for poor health and based on their socioeconomic conditions, and socio meaning including racism, right? And so when we think about types of health disparities, we're talking about things from insurance coverage, right, to access and use of care, to the quality of care people are getting. And we include some examples there. I don't want to take up too much time. But then when we move to healthcare itself, there are examples of individual racism, right, and institutional and systemic racism. And so we wanted to go through some of those quickly with you just to help frame some of your breakout session conversations. And so we all know about clinician bias, right? Actual physicians, nurses, administrators, and those in the healthcare industry practicing sort of racist, not just sort of, but practices in their everyday working situations, right? Everything from the asking of questions during medical exams and clinical interviews to assessments that they make based on their own assumptions and biases about patients and clients, and what they assume will be the conscientiousness or effectiveness of symptom management by those patients, their willingness to seek different kinds of treatment, and what kinds of specialty care they're referred to, whether or not they get those referrals, whether or not there's resistance to referrals, and then the interpersonal behaviors that lead to patient trust and mistrust. So someone's got an allergy. And so we wanted to talk about what institutional racism in healthcare might look like too. Willis, do you want to talk about some of this? I don't want to talk the entire time.
There we go. Let me unmute myself. There we go. So when we talk about institutional racism in healthcare, you know, there's 3 things you really want to focus on: lack of economic access to healthcare, the deficits in hospitals and healthcare institutions, and lack of physicians and other providers. So if we go back to the top, you know, a great example is the Welfare Reform Act in 1996, which resulted in a reduction in use of Medicaid by those who qualify. So for example, you know, with that, if you didn't have employment, then you couldn't get Medicaid. If you don't have Medicaid, and then something happens to you. Now you're in that gray area of being, you know, disenfranchised. And when we talk about, you know, deficits within healthcare institutions, so the adoption, administration, and implementation of policies and funding practices, you know, that restrict admissions, closures, relocations. So, you know, a great example, if you have something going on, but within your area that there's no physicians, and then there might be a physician 30 minutes away, but they don't take your health insurance. You might not even have a vehicle to get over there. You might not feel even comfortable within that area. You know, again, which I kind of made with my last point, lack of physicians and other providers. You know, discrimination within post-secondary education happens a lot when we start to talk about healthcare, which is not really talked about a lot when we're talking about being in school and being discriminated against, you know, and things of that nature. Racial biases within testing, you know, so going in and you might have something going on and the doctor might say, well, you know what, it could be because of this based on your racial background. It could be, or we're not going to test this because I don't feel like you need it. You know, you say you're in pain, but have you done any drugs lately or anything like that, of those biases that are very important? You know, quality of life issue that affects school performance. You know, when you're talking about having health issues within school and they're not being acknowledged, or even when you're talking about from a mental health point, you know, that's not acknowledged. And when you start to think about that and the deficits as well.
Yeah, one challenge we hear about a lot on our own campus is a lack of access to health, both, you know, physical, pharmaceutical access, as well as physicians and mental health providers and such for our trans and gender non-binary folks of color across staff, faculty, and student lines. And not only do we have a lack of professionals in our region in those areas, but then if the mechanism is toward telehealth or accessing, you know, especially in the COVID-19 situation, and there are still insurance challenges with UC Path or different kinds of processes to access that care, institutionally, we're still not able to make the process of access and affordability as easy as possible for our own community, right? Go ahead, Willie.
So I also keep going, discriminatory practices, policies and practice. So medical redlining, excessive wait times, unequal access to emergency care, you know, deposit requirements as a prerequisite to care. And I just want to stop there because I love to use the example of my wife and I literally just had a baby 6 months ago. And the one thing I remember is when she went into labor and we went to the hospital, before they did any work on my wife, they said, well, we need your copay. And my first thought to my wife of, you know, doing the work that I do for a living is, what if I was someone who didn't have the copay and my wife's in labor? You know, now I got to be worried about treatment. Is she going to be cared for? How she's going to be cared for? You know, these are things that when you're privileged and you have insurance, so you do have the monies, you don't think about this. You know, miscommunication and mistreatment, you know, with those who have limited proficiency in English. You know, I've heard many cases and even witnessed it, you know, within my own life of watching people who, you know, who don't, English is not their primary language, and watching nurses just blow them off. Or, you know, they're trying to see where their child or spouse is and they can't communicate and the nurse just completely forgets about them or whatnot. You know, racial disparities in medical treatment. Research has shown that 50% of Black people in the U.S. only use about 10% of the hospitals in the country. And those hospitals termed minority-serving institutions tend to be of lower quality. This trend is a direct result of the country's historical racial redlining. And when you even talk about redlining, we have to remember that that's only about 40-some years old of the restrictions against redlining. So it's not that old, you know, of policies put in place when you talk about disparities of what's going on, you know, and of economic segregation of communities. You know, my wife, again, when she was pregnant, she said, I want this to be my hospital and not this area because it's a better hospital. Well, they all should be good hospitals in general. Next slide, Mary. So systematic racial discrimination in medicine. So a survey conducted by WebMD and Medscape found that 59% of physicians have heard offensive discriminatory remarks about a personal characteristic in the last 5 years. So examples, a doctor's youthfulness, their gender, their race, or even their ethnicity. You know, and a great one I've heard is, Are you a doctor or are you a nurse? Like, you might nurse and they might be, you know, the on-floor physician, you know, for that shift. You know, even the American Medical Association found that despite maintaining a normal productivity rate, Blacks and other minoritized doctors gain promotions at a much slower rate than their white colleagues. African American doctors report being called, you know, all type of racial terms, and even being asked to relinquish care because they're not white per se, as in this example. These are things that sometimes I didn't even think about this to putting these slides together, because I'm always looking at it just what I'm dealing with. But what about the individuals who are in the medical field? What are the disparities that they're dealing with as well that needs to be discussed? Asian Americans identified physicians reported being demeaned with long-standing cultural and racial stereotypes by not only the patients, but also your colleagues. So it's bad enough when you're going in to help someone and they're discriminated against you or whatnot, but the individuals that you share a space with, an office with or whatever, they're doing the same things as well. So you have to think about from a health standpoint, and as I mentioned earlier, mental health standpoint, these are very, very disheartening. Next slide. There's a lot, you know, also when we're still talking about discriminatory efforts, we have to talk about gender discrimination as well. So there's a lot of great examples here. I'll just read some. Despite there being more women in medicine than ever before, give a hand clap for that one, female physicians have a higher rate of depression than women with doctoral degrees in other fields. That's really, really crazy. You know, in 2017, a survey questioned 6,000 women physicians about workplace discrimination. 78 experienced some type of discrimination while working. Gender discrimination was reported by 66%, while maternal discrimination was recognized by 35% of women. These are huge numbers. Anything over 1% is horrible in my book, if you're asking me. And we're talking 30%, 70%. These are things where I'm happy we have this forum today so this can be discussed. You know, another one, female doctors reported being sexually harassed by patients.
We can't hear you.
Uh-oh, his audio disconnected.
Okay, maybe I'll jump in. And so moving to trying to close out on what things we can all do individually, institutionally, and systemically, making sure you know your rights, having more frequent conversations about these issues, even if they're uncomfortable or awkward, or you don't feel you have the right vocabulary yet to do them without offending anyone. That's when you can reach out to offices like ours to help you with the vocabulary and facilitating the difficult conversations, right? Confronting your own biases. Don't be defensive when folks call you out on your own biases and inappropriate statements, right? Reach out to subject matter experts. Don't expect the person you've just offended to explain to you why they're offended. And become a co-conspirator as opposed to just an ally who sympathizes with another, to actually figure out what is systemically, institutionally happening that is creating these kinds of opinions and biases, and then working to dismantle those structures with the policy and process changes that others have mentioned. And then being an active bystander, right? We all see it happening and everyone's too stupefied or shocked and awed to say anything. And then the moment lingers and the folks who are offended feel like everyone in that space just let it happen and is endorsing that perpetration, right? So be the one to step up if you can tell other people are rattled, intervene, right? Often these things happen when supervisors or others in a position of authority are not around. And so diffusing the situations, reducing the hurtful behavior, you're creating a healthier, more inclusive climate, refusing to laugh and participate, and then notifying supervisors after the fact, and then encouraging other bystanders. Willis, are you okay? Do you want me to continue?
Yes, yes, I apologize. I think those who like to discriminate against people won't let me be great, so they cut my connection. But no, it's very important that we encourage bystanders. Man, I was literally on a training today talking about that, about how you can be, you know, not only an ally, but a co-conspirator as a bystander. So even if you're not the one experiencing, you know, the bias or the discrimination, you know, so I'll just read it. There may be various blocks that prevent victims and bystanders from acting. Being an active bystander requires several steps. Recognizing that something happened that is worthy of a response, feeling responsible for responding, choosing how to act, and taking action. So with that, I always begin with, make sure you feel comfortable. Don't just say, hey, you know what, I was on this training and there was this cool person named Willis and he said, if you hear something, see something, speak up. Make sure you feel comfortable first. And then also make sure not only you feel comfortable within yourself, but also the space that you're in as well, because those are two different things. If you check those boxes out, then I'll say run for it. You know, with that, you can call it out. You know, you can do simple things. What did you mean by that? Or I don't think I heard you correctly. Or could you go in more detail, please? You know, and also the individual whom it happened to, you know, checking on them. Are you okay? You know, even asking prior to saying something, would you like for me to speak up for you? You know, these are important things if you're going to be a bystander or a co-conspirator, you know, but with that, on our website, as Miriam recently had the slides up, there's a lot of things that we've covered in these slides. There's things that we didn't go in full detail. On our website, you know, the Office of Diversity, Equity, and Inclusion, we have a million tons of resources. And so resources regards of understanding even more detail, diversity, equity, and inclusion, how that breaks down when we start to talk about microaggressions and positionality, which plays a huge role when you're talking about health equity. All these things play a role, so please look at that. Also, being that I used to work in HR, I'm always talking about our learning management system and utilizing our management system. So within our learning management system, we have a whole course on implicit bias. There's a series. Each one is about 20 to 35 minutes. There's a test after each I want to say session, but it's not session. I can't think of the name of it. And as you see, I have them all. We have modules. There you go. You know, and these are really, really good because it really breaks it down concept by concept, and then you get to take a little quiz after it. And it's just great for organization development, career growth, and just being a decent person as well. I would like to say.
There's also the UC People Management Certificate. We found from our Campus Culture Task Force that folks across campus are very frustrated that people get promoted into higher positions, supervisorial, managerial positions, department chairs, deans, associate deans type positions with very little management training, and that they could really use help in those areas to effectively deal with conflict resolution and such. And so some introductory materials and such are some of these other modules online. And then we have many resources offices on campus that are happy to help as well. What we're finding is that Black Lives Matter and COVID-19 is triggering a lot of departments into having to address longstanding resolutions that have not been completed in their own departments, and this is across all the colleges and administrative staff, organizational units as well. And so for each of these units to really go back through and review their policies and processes that would lead to a kind of transformative justice practice that would change the processes in the department that have led to these kinds of inequities and racism to begin with would be one way of addressing institutional disparities and inequities at every single level, every single unit. And then finally, because it's going to take more than just individual units on campus, here are some other events going on. We partnered with Staff Assembly to have a conversation next week on white fragility and privilege. They've been reading the Robin DiAngelo book. I believe they're reading How to Be an Anti-Racist next. And then we have our first inaugural DEI Graduate Summit in the second week of September. And then the DEI Climate Council Forum, that is the evolution of the Campus Culture Task Force to try to continue working on implementation for accountability measures on campus, will proceed after that. And then this is our contact info should you want to reach any of us. I'm going to stop share now, and we can make this slide deck available if anybody wants to access it later.
Thank you so much, Miriam and Willis. Really appreciate that information.